Good evening, everyone. Today's class is on one image, one clinical pearl in posterior segment masses. This session is moderated by Dr. G. Suganeswari ma'am, and this would be mostly an interactive session. So you can also pick up on the red and yellow nuggets, which you'll see throughout the presentation. So case 1, a 39-year-old female who complains of metamorphopsia of only right eye since 6 months had presented to the VR department. Visual acuity was 6/9. I am only putting the eye of interest. The other eye, left eye, is unremarkable. So as you can see, this is the clearest image of the right eye, which is showing the presence of pale to yellow, it's slightly orange, placoid lesion, juxtapapillary in position with defined scalloped margins or geographic margins and pseudopodia-like projections. Over the surface, you can also see RP hyperplasia. You take away from this that it has a placoid appearance, it has a pseudopodia-like projections, and it's pale in yellow. This is the autofluorescence of the same eye, which shows the granular hypoautofluorescence with hyperautofluorescence. Usually, calcific areas will show this hyperautofluorescence, and decalcified shows the hypoautofluorescence. On ultrasound, you have a placoid-like. Ma'am?
You just slow down. See what will happen is if you rush through, they may not be able to kind of digest what it is. So okay, they have to sink in with the image. So like, see, she's going to show you multiple cases. So from that, the most salient feature, you can all see that, and in case you have any doubts, you can ask also. So you can go to the previous image, so because that I think. So now in this, see, we are going image by image. The idea is you will have one particular disease. She will kind of make one pearls together and make it a garland. That's the idea. So every image, that salient feature will be there. So try to appreciate that. And in case you have any doubts, you can always ask. So now in this particular fundus image, you are seeing a hypopigmented lesion or an amelanotic lesion, if you would like to call that as, and the location. So where is the site of the lesion? Because sometimes these things do give you a clue as the peripapillary location or within the posterior pole. How does the margin appear like? So the one particular very important finding is what has been projected on here. So appreciate the borders, how it appears. So these are, not everything will be like this. You may have a larger lesion like this or a smaller lesion. So right now you will have to kind of find out now if a particular case comes like this to you, what would be your differentials looking at the fundus photograph alone. So how many of you thought that this is osteoma? How many of you thought as something else?
So RP alterations with actually, I don't have the depth perception of this, so I cannot comment how it is elevated or what, but the color-wise, the RP looks altered in that area.
So did any one of you thought it could be a choroiditis also?
Yeah, the margins
because it's only a fundus photograph, isn't it? So like, you don't have the depth perception. So when you look at the fundus photograph, so it's a flat lesion, and depigmented lesions, differentials are not too many. It's easy to pick it up. But if I say this is going to be a subretinal hemorrhage, altered subretinal, so how many of you would say yes? How many of you would say no for it? Which one? Subretinal hemorrhage. No, when it gets dehemoglobinized, then obviously the color changes, isn't it? You can have as white as this also. So now looking at this, what are the other things which you will have to see is what we will go through one by one like that. So now when you see the autofluorescence, go to the next one. So the first takeaway is a placoid lesion. That is what is the first one. The second takeaway is?
You see over here, there is a hyperautofluorescence with an interspersed with hypoautofluorescence. Usually hyperautofluorescence is due to the preserved RP function, and that suggests like a calcific areas, whereas the decalcified areas are usually hypoautofluorescent, potentially suggesting maybe RP atrophy or dysfunction.
So when do you get hyperautofluorescence?
Overworking RPs.
So metabolically sound RP, that is what it is. So that is why you get hyperautofluorescence. So hyper will come only in the area where you have functioning RP. When you have defunctioning RP, then that goes into hypoautofluorescence. This is the thing that will that is what you see on a autofluorescence in an osteoma. Yeah, go to the next.
So this is the ultrasound image, uh, which is showing a placoid lesion. You can see just adjacent to the optic nerve head. And the most significant is you can see a high A spike, which is seen. Along with that, you have a posterior back shadowing, which is seen within the orbital fat. Can anybody name this sign? Yeah, it's called pseudo-optic nerve sign. And this is characteristic for choroidal osteomas. So the OCT was done. OCT shows a elevated retinochoroidal counter. The thing to look for is you can see that the retinal layers are almost intact. So the integrity is maintained. Whereas the outer layers, there is this posterior back shadowing, and also there is underlying RP thickening which is seen along with a pocket of subretinal fluid. One more thing I would like to point out is, can you see the back shadowing? It is not like a uniform back shadowing. There are like lines in between. It's like lamellar. So the reason why you're seeing this back shadowing is there is partially calcified and decalcified. So when the rays pass through, it is not even. It goes through a calcific area and a decalcific. So that's why you're seeing these segmentation lines, like sort of back shadowing, which is seen. So this is a diagnosis. It's a choroidal osteoma. Usually they are unilateral and benign idiopathic ossifying tumors. They are characterized by the mature bone which is replacing the choroid. It has a female predilection with a slow progression, and usually they are with good visual prognosis, but can advance during the adolescent age. They are asymptomatic, but vision loss can occur when there is the macular location of the tumor or the CNVM, and when there is decalcification and atrophy of the RPE. It is usually confirmed by multimodal imaging like ultrasound, OCT, and our fundus images and autofluorescence, which we have seen. Pseudo-optic nerve sign is an important sign to remember. And if CNVM does occur in such kind of patients, it is seen it occurs like in around 32% of the cases over 5 years, and it gradually progresses over the years. The treatment, if you see CNVM, the treatment is anti-VEGF, and then there is a variable visual prognosis. OCT is mostly for monitoring and for prognosis of this disease. One more thing is, if you're seeing a young female patient with spontaneous choroidal hemorrhage, always keep the option of choroidal osteoma in mind, always a differential. So what are the differentials? Amelanotic choroidal melanomas. These are usually elevated, yellow-brown with ill-defined margins. They have an acoustic hollow which is seen on ultrasound, and they have a low to medium internal reflectivity. Whereas choroidal granulomas are inflammatory in origin. They are mostly seen in the periphery, yellowish white, and they're associated with systemic causes. They're treated with corticosteroids. Choroidal hemangiomas, you cannot appreciate it, but it is seen. It's a reddish orange like hue with vascularity, and it has a high internal reflectivity. There is a discrete choroidal thickening also seen on OCT. Amelanotic nevus has indistinct margins. It is yellowish brown in color. They are mostly asymptomatic, but they appear as hyperreflective on infrared imaging.
Go to the next case. This choroidal osteomas. Do you have any entity called as secondary choroidal osteomas also? As a secondary feature, like you have secondary Coates response like that. Do you have something like that? Long-standing choroidal diseases can also have this osteoma. What is an osteoma? Osteoma is nothing but a metaplasia, isn't it? So it's a metaplasia. Metaplasia can occur in long-standing diseases. So nowadays what we also tend to see is patients who are having long-standing choroidal granulomas types like that, they are also having these metaplastic transformations which we are seeing. And sometimes in multiple myeloma also you can get to see these this deposition of calcium. What are the other conditions in which you may have a calcium deposition in your eye? Where else you can have calcium?
Retinoblastoma.
Okay, then it's okay. It is only interactive class. So we are just thinking loud. If calcium is there, what and all could be the other differentials? Like Dr. VJP asked for the ultrasound. What would be your differential for that ultrasound?
Toxocara granuloma.
Toxocara granuloma.
One more thing you can take back is you can read EDI OCT features of choroidal osteoma. Yeah. So case 2, a 40-year-old male who presented with a gradual decrease of vision in the right eye since 1 month. Visual acuity was 618. Anterior segment was within normal limits. I put up an enlarged image. Wait, yeah. So you can see this is the lesion, and the surrounding it, there is a pocket of, there's like subretinal fluid surrounding the lesion. So this is a solitary, creamy colored pigmented lesion, slightly pigmented, with a plateau-like configuration in the posterior pole with indistinct margins and surrounding subretinal fluid. So keeping in mind, we just thought it to be like a hemangioma because it was almost looking similar to choroid. We did a USG. USG shows a solid, shallow mass, which is irregular in contour, has a regular internal structure with low surface and moderate internal reflectivity. There is also an exudative retinal detachment component. And you can also see there's a low height to the base ratio. So biopsy was done initially.
Stop at that
Yes,
image which was there in the front. So now if you see the fundus photo, okay, you are seeing some amount of, go back to the fundus photo. Yeah, now you see what is more prominent here. Some orangish things, though not completely the orange, this is a globular lesion. You can see some orangish lesions here. It's a very uniform dome-shaped lesion. And on ultrasound, when you go and see the ultrasound, yes, you see what is the height of the lesion and what is the transverse diameter. Because many a times this will give you a clue to differentiate it from a benign from a malignant condition also.
I think shallow you use when there's a fluid level or something. Like you have a shallow river, a shallow pond. Like that, you have a shallow retinal detachment or a bullous retinal detachment. This is a dome-shaped mass,
Yes, ma'am.
right?
So biopsy was done for this patient, and we noticed that he had a fibrocollagenous stroma with lots of extravasated RBCs. There were a few spindle cells, as you can see in this last slide, but there was not much of pigmentation. So we ruled out any melanotic lesions. Usually biopsy is mostly for confirmatory and for staging of the disease. And then we asked for a CT brain with an MRI screening, which was done. MRI shows this peripherally enhancing T2 hypointense lesion. Usually they can appear hyperintense, but on rare occasions it can be hypointense. PET CT with FDG, it showed a non-avid T2 intermediate signal with like a dome-shaped lesion within the right eye. And this was our PET CT. You can see multiple metabolically active lesions seen throughout the lung, the mediastinum, the hilar lymph nodes, and sacroiliac joints. This patient, the features were mostly suggestive of a carcinoma of the lung. This is the PET with a PET scan, which is showing this multiply active lesions where you can see this. And there was ipsilateral hilar and mediastinal lymph node spread with left pleuropulmonary, skeletal, brain, and right choroidal metastasis. So this is a case of a choroidal metastasis. Usually metastasis occur due to hematogenous spread from the carcinomas. The most common site of primary malignancy in females is breast, and in lung is usually males. Primary tumors are usually well vascularized, but metastatic lesions are avascular. They can be either multifocal or bilateral. Another thing I want to highlight is always look for the other eye, because metastases are not a single lesion. They can occur in the other eye. However, in this patient, the left eye was within normal limits. Rarely these lesions, as we have seen, they were not much pigmented, but they can be very much pigmented. Then you have to suspect any renal or carcinoid in origin. They can have this orange reddish in color. The surface also, it has clusters of dark pigmented cells which is seen, and it's called the leopard skin-like pattern. It can appear sometimes. Location, mostly 40% of the time it is usually post-equatorial and being located close to the macula. Biopsy is always indicated in high suspicion of cases with metastasis without any primary malignancy. He initially didn't present with any of the symptoms, and we didn't even suspect malignancy until PET MRI was done. Seismic workup is always relevant. Look for any cancer biomarkers after you have seen the MRI. Do mammography for females as well. Do CT, MRI, and PET imaging of the chest, abdomen, and the pelvis. Treatment-wise, breast carcinomas, their patients are treated with hormonal therapy. Radiation therapy is for focal and diffuse lesions, but external beam radiotherapy is done for multiple diffuse lesions. Episcleral proton beam therapy is for focal and solitary lesions. TTT and PTT have been advocated for small, solitary choroidal lesions with a thickness of less than 3.5 mm and with a minimal subretinal fluid. Enucleation is the last resort in a painful blind eye. The differentials include first a choroidal tuberculoma. These are mostly seen posterior to the equator or to the periphery. They have this contact sign which is seen on OCT where the granuloma is almost just above the in the retinal layers and which is causing a choroidal elevation. You have a variable internal reflectivity and it's mostly inflammatory in origin. Amelanotic choroidal melanoma, they have this intense hyperautofluorescent which is seen, hyperechoic on ultrasound and hypoautofluorescent on ICGS. Melanomas, they appear as a unilateral, unifocal, dome-shaped lesion, highly pigmented. They're mostly very vascular tumors and it's a malignant tumor. They have this low internal reflectivity with a collar button-like appearance. This is due to the break in the Brooks membrane. Posterior scleritis also they present. Sometimes they have this pain with a boggy, soft swelling. And there's also the T sign which is seen on ultrasound. This is a 43-year-old male who presented with defective vision of the left eye since 1 week. Anterior segment was within normal limits. Visual acuity was 3/60. It was improving with +3 to 6/18. Orange, it's actually an orange solitary oval to discoid lesion in the posterior pole, which is almost having a similar appearance to that of the choroid. We got an ICG and FFA done initial for this patient. So these are the early phases where you can see that the lesion is hypofluorescent with a surrounding hyperfluorescent. On ICG here you have this lacy like pattern. You're seeing just hyperfluorescent interspersed with hypo. As the FFA, as the phases are increasing, then you can see the hyperfluorescence which is increasing throughout the phases. And even there is a rapid filling up of the dye within the tumor cells and there is a rapid washout phenomenon. So there is also visualization of intrinsic vessels which can be seen if you just magnify it. OCT was done for this patient which shows a smooth dome-shaped elevation. There is a low hyperreflective signal. This elevation is almost it has a gentle slope with outer retinal schisis and there is also presence of subretinal fluid. So this is a case of a choroidal hemangioma. It is usually a benign non-melanocytic hematomatous uveal tumors. They have a male preponderance, most commonly located in the macular area or in the peripapillary area. Two types have been described, circumscribed and diffuse. This is a lesion of a circumscribed hemangioma. There is no systemic association, usually seen with an adult age. Vision loss, if it occurs, it is mostly due to cystoid macular edema or macular schisis, or if there is any retinal detachment. One more thing to notice was I told initially that there was a vision improvement with +3. So these patients usually they have this hypermetropic aspect. And on OCTA, you can have this club-like appearance, which is seen on the deeper choroidal slabs. The active tumors have this signal void areas in the deeper slabs, which is suggestive of dormant tumors. On ultrasound, there is a high surface and internal reflectivity. With a normal choroid, there is no backshadowing seen, since it's a vascular tumor. And it has a less diameter to height ratio. Diffuse hemangiomas, on the other hand, they present with systemic associations, mostly Sturge-Weber's. And these tumors are extremely bright. They have this brilliant red reflex. They are like reddish to orange in color. And as soon as you put the IDO, you see this tomato ketchup-like fundus appearance. And ultrasound, it again shows the thickened choroid with medium to high internal reflectivity. Sometimes these patients, they can have this glaucoma can develop because of this congenital glaucoma due to nevus flemmus. The treatment modalities, photodynamic therapy is usually preferred for tumors involving the macula. The dye vertiporphin is injected and then the laser has been done at a energy of 600 megawatts per centimeter square. The advantage of this is there is a selected target of the tumor vessels, thus leading to its regression and reduction of the subretinal fluid. Transpupillary therapy has also been advocated for tumor bases less than 10 mm and a thickness of less than 4 mm. The only complications are you can develop cystoid macular edema or pre-retinal fibrosis, and these are not suitable for peripapillary tumors. Radiotherapy is done for cases where they have extensive retinal detachments, and that is usually difficult to treat with PDT. When there is a frank retinal detachment, you can go in for surgery like scleral buckle or pars plana vitrectomy. If there is an associated glaucoma component, combine it with a filtering surgery. Propranolol in the doses of 2 mg per kg per day, it has been shown to promote acceleration of the subretinal fluid. What differentials do you think of? The first thing is either a circumscribed or a diffuse. The other things are choroidal nevus. Choroidal nevus, usually they are flat and acoustically solid lesions. They do not have any features on ICGA except for a hypofluorescent patch. Osteomas we just discussed. Nodular scleritis, they have this moderate to high internal reflectivity seen on A scan, and they're hyperfluorescent on FFA. Metastases usually have a variable reflectivity, and there is a slow filling due to the poor circulation pattern. The thing to remember is this washout phenomenon is typically only for choroidal hemangiomas. So there is bilateral disc edema with blurred margins, and you have this vitreous haze is also present. With peripherally, you have this yellow elevated subretinal lesion which is seen inferotemporal to the fovea. Ultrasound was done. I'm sorry, this is the scan I have, but both eyes it has this retinochoroidal mass lesion which is noted in the ITQ with moderate surface reflectivity and a uniform internal low internal reflectivity with choroidal thickening also is seen. So yeah, we were suspecting some inflammatory pathology. So serological investigations were done. Complete blood picture had a lymphopenia count. Interferon gamma release assay was negative. MON2 also was less than 10. Serum AC was 28 units. Quantiferon, however, was positive. LFT, RFT was within normal limits. So we kept a suspicion of tuberculous pathology, so probably a tuberculous choroidal granuloma in mind. OCT was done. OCT shows this multiple hyperreflective dots which is seen within the vitreous cavity. And you can also see there is this undulating choroidal folds which are also there. Retinal layers, however, are almost normal, and there is also a pocket of subretinal fluid. This is the OCT which is going through the granuloma lesion, and you can see there is this hyperreflective material which is seen, and this multilaminar hyperreflective structure which is seen in the center. Can anybody name this sign? Where you can see the hyperreflective material within the photoreceptors. It's just being stretched out. Yeah, it's called Ballard. So Ballard is a bacillary layer detachment where there is a detachment between the inner segments of the photoreceptors.
So just stop at this OCT.
Yes, ma'am.
So initially I was telling you, whenever you have a choroidal lesion, you can also look at the OCT into the vitreous echo. See here how this vitreous is appearing. And also the neurosensory retina, how it is looking. So from that also you can get a clue whether you're dealing with an infective inflammatory or you're dealing with an infiltrative pathology. And one more thing I would like to point out, see, for some time, if your neurosensory retina was normal, compact, but you still had this bumpy RPs, okay, bumpy RP, or the choroid was undulating like this. One another differential you must think is probably if you had a lymphoma, which is a uveal lymphoma, not your PVRL. PVRL will again have some of these features of, sub-RPE infiltrations like that. But if you have a straightforward uveal lymphoma, which can be a T-cell lymphoma also, those lesions can present like this. If you have these undulating choroidal lesions, choroid is fully undulating like that, thickened uveal tissue, that can be one of your differentials. And in that, you may or may not have the involvement of your vitreous, because your T-cell lymphomas or if your uveal lymphomas, then in that case the vitreous may not get involved as a primary. But in PVRL, of course, it will start from the vitreous, and if you have not managed the vitreous well, then that's when it goes into the sub-RP infiltration. And they are all like those FFAs, if you see, of a lymphoma FFAs, they will be silent FFAs. You will not have any, because that is an infiltrative pathology. It is not an inflammatory pathology. So that is what is your differential.
So FFA ICGA was done, and you can see there is a hyperfluorescent lesion which is seen. It progressively, there is a hypofluorescent, but it's surrounded by this hyperfluorescent margins. And on ICGA, you have this blocked fluorescence which is seen throughout all the phases. So we ruled out metastasis, because this is how a metastatic lesion looks. So we ruled out metastasis. Because this is how metastasis looks. So the initial phases, you have a hypofluorescent, which slowly progress to become hyperfluorescent. And on the surface of the lesion also, you have these pinpoint hyperfluorescent spots, which are seen usually in metastasis. They're suggestive of like the non-vessels, like the small hyperfluorescent spots which are there. One more thing was CCT chest was done. Meanwhile, he got a picture of a multiple enlarged non-caseating mediastinal and both hilar lymphadenopathy was seen. So it favors suggestive of a granulomatous pathology, more likely of a sarcoid than of a tuberculous pathology. So depending on IWAS criteria for diagnosis of ocular sarcoid, we had two features suggestive of systemic, where you had lymphopenia and also you had this bilateral hilar lymphadenopathy, which was positive. And among the ocular features, you had this bilaterality and this optic disc involvement also was seen. So this is a case of a presumed ocular sarcoidosis. You can read over here, definitive means the diagnosis is supported with biopsy, which in our patient we had not done. Presumed, where the diagnosis is not supported by biopsy, but either BHL is present with either two intraocular signs. And probable is when the diagnosis is not supported by biopsy or BHL, but there are just signs and two systemic investigations. So finally, this patient was treated with mycophenolate mofetil and oral corticosteroids were given. You can see very well resolution of the tumor, of the granuloma, and also you can see that overall the generalized retina has also appears more healthy, and the lesion has become much localized. This is after 6 weeks. Same thing for the OCT. You can see the hyperreflective dots also have reduced and the granuloma has completely shrunk down. So posterior involvement is less common with choroidal involvement, which is described in only 5% of the patients with ocular sarcoid. They appear as this pale yellow, well-defined choroidal lesions. They have an irregular border. They are usually vision threatening, meaning they can be located in or near the macula, and they are associated with sensory neurosensory detachment, and sometimes it can lead to atrophy. EDI OCT demonstrates the homogeneous shadowing which is seen within the choroid. If at all you suspect an ocular sarcoid, always go for a systemic workup. Mostly the HRCT of the chest should be done. Tissue biopsy is, however, confirmatory, and sometimes diagnostic vitrectomy has provided a diagnosis of sarcoid in around 42% of the patients, but it is only just supportive. It is not a definitive in cases of presumed ocular sarcoid. Treatment, mostly corticosteroids are the mainstay. Local steroid therapies have been given, like posterior subtenons, and steroid-sparing immunosuppressive agents are also effective in treating. Systemically, if long-term therapy with corticosteroids or immunomodulators are not possible, then you can go for azathioprine, higher doses if they're not responding. The closest differential you come close is tuberculous choroidal granuloma. These tuberculous granulomas are very much yellowish and white in color. They have an exudative RD which is out of proportion, and they are very large and they can be ill-defined. You have this hypofluorescent choroidal lesion seen on ICGA with fuzzy borders, and they are usually treated with anti-tubercular therapy and corticosteroids. The other differentials are metastasis, amelanotic melanomas, and lymphomas. Lymphomas, as just ma'am has told, they are multifocal creamy yellow patches seen at the level of the choroid, often with SRF. They have this granular appearance which is seen on FFA, and sometimes on OCT you have the segments of RP that are nodular and they are elevated, hyperreflective and detached. So this is just a summary of all the benign lesions which we have seen. You can read it at your leisure. So coming to case 5. This is a 26-year-old male who presented with blurring of vision of the left eye since 1 year. Visual acuity was 1/60. IOP was within normal limits. This is the optos image of the left eye. As you can see, there is a dome-shaped pigmented elevation which is almost occupying 50% of the vitreous cavity, and also there is an inferior retinal detachment. I kept the slit lamp photo. As you can see that the tumor is seen through the just dilated slit lamp examination. Whenever you see tumors like this, always look at the conjunctiva, look at the conjunctival vessels, see for any sentinel vessels which can appear at the site of the lesion. An ultrasound was done which shows a diffuse mass lesion. It has a low surface reflectivity, as you can see, with moderate internal reflectivity. One more thing to note is look for the extrascleral extension, and there was also the presence of retinal detachment. MRI report was done, which showed a hypo-intense lesion on T2 and a hyper-intense on T1. Contrast enhancement was present. So this patient, we were suspecting any malignant pathology. So histopathology was done, which showed a spindle cell tumor. There was no pigmentation, and you can see the cells which are arranged in a story form like pattern. These are these origami things which we used to, that has an appearance of a story form. You can see the cells which are all just merging around. So that is called story form. One thing to note was there was a low NC ratio. So when you're dealing with a low NC ratio, probably it is not malignant. That should be kept in mind. And then IHC was done. IHC is always confirmatory. You can see here S100 was negative, and SMA, Desmin, and Vimentin. So these three markers are usually for the muscle actin. So whenever you see these three being positive, you should suspect any ciliary muscle pathology which is undergoing. And CD34 and HMB45, these are mostly for melanomas. These were negative. So an impression of ciliary body leiomyoma was made. This is gold standard. So ciliary body leiomyomas usually they are benign. They are very slow growing, as you can see, 1 year of age. Smooth amelanotic lesions, but they are destructive in their wake. They can involve whole of the vitreous cavity and even cause scleral ectasia. Sometimes even spread to the extrascleral space can cause, there are higher chances of metastasis. Treatment usually includes the observation for small size tumors, whereas if there is a tumor less than 4 clock hours, you can go sclerouvectomy or transscleral resection can be done. Mostly the complications when you do such procedures are like vitreous hemorrhage, cataracts. It can impinge onto the lens and cause cataract and also angle closure. And hemorrhagic choroidal detachments also noted. Plaque brachytherapy, a dose of less than 50 gray units tolerated. Enucleation is done for large tumors. So this patient was enucleated because he had other factors like poor vision, long standing, and usually they are not associated with any systemic findings and they are non-life threatening. Vision loss is mostly due to RDs or neovascular glaucoma and painful blind eyes. The closest differential is melanomas. Melanomas, however, they have this iris neovascularization can occur, and sometimes they can present with ectropia nuvae or chorectopia. They have this low to medium reflectivity seen on ultrasound. Excavation can be present. Treatment includes local resection, radiotherapy, and enucleation. Other differentials include ciliary body schwannoma, medulloepithelioma, adenoma of the ciliary body. 58-year-old female who presented with a visual acuity of 6 by 7.5. She's phakic. She just came for a regular checkup. And upon examination, this is the optos image of the left eye. As you can see, there is a pigmented elevated mass which is seen at the optic disc, and there is this intense pigment dispersion which is seen just adjacent to the lesion. OCTA was done. It has a characteristic, this hyper-reflective margins of the lesion with dense posterior backshadowing. On the OCTA over here, you can notice this multiple hyper-reflective lesions which are seen, that is suggestive of the tumor cells within the optic disc melanocytoma. And so biopsy was done. The only reason being we were seeing this pigment dispersion, and it was a fairly large elevated lesion. So on biopsy, it showed bleached polyhedral cells were seen with abundant cytoplasm, and there was a low NC ratio. A lot of dense melanin pigment was also seen. This was suggestive of a melanocytoma, and usually biopsy is always confirmatory. So optic disc melanocytomas are congenital. They are non-hereditary, usually benign, darkly pigmented lesions. Male is to female preponderance is equal. Mean age, they can occur in 50-year-old, but they have been noticed to occur in even 1 year of age or even at 91 years of age. They are usually stationary lesion and they are slow growing. These patients usually present with an enlarged blind spot, which is usually seen. There is no subretinal fluid or hemorrhage in typical cases of melanocytomas. OCT and FFA can help differentiate it from a choroidal melanoma. The differentials include optic nerve head melanoma, which these are mostly more aggressive. They show a rapid growth, mostly exudation and hemorrhage also. Optic disc drusen, they can appear similarly, but they are more calcified, seen on B scan. Peripapillary nevus can resemble a melanocytoma, but usually do not involve the optic disc. And optic glioma, they're mostly seen in children. So case 7, a 57-year-old male who came in 2017, this is the 2017. Yes, sir.
The pigmentation dispersed, no? Was it on the retinal surface or was it in the vitreous? That OCT is not.
It was on the OCT, it's not seen, sir, but
Into the vitreous.
vitreous mostly, sir, because you can see these hyperreflective dots which are seen, but whereas on the retinal surface, the OCT appears quiet.
See, the indication for this patient to have this much of pigment is why a biopsy was done, because so much of pigment dispersion and the age of the patient, 62 years. So 62 and with so much pigment dispersion, we don't expect it. Is usually it starts growing at the adolescent age when hormonal activity is more, not at this end of age groups. So that is why that becomes an indication. So now when you see the next patient, that's why we put back to back,
A 57-year-old male who came in 2017 initially, visual acuity was 6.6 in the right eye. There was a gradual progressive diminution of vision over the years. Patient had come again in 2025. The vision was 6.18. As you can see, the lesion, the same optic nerve had melanocytoma. It has increased in size, increased in pigmentation, and also there was a surrounding subretinal fluid. On ultrasound in 2017, you can see there's a small dome-shaped elevation which is having high surface reflectivity, and over the years it has increased in size. This ultrasound is how it should be done. The dimension should be placed at least above or behind it. So it had increased in size with the exudative retinal detachment seen just adjacent to the lesion. Even on OCT, you can see that the lesion has increased. There is an elevated mass at the optic nerve head with inner retinal hyperreflectivity and complete posterior backshadowing. FFA was done, which showed that there was a blocked hypofluorescence seen at the disc, which was persisting in all the phases. And then a biopsy was done for this patient. I do not have the biopsy report, but the serial section showed that there were multiple spindle B cells with nucleoli, and there was also small epithelioid cells suggestive of a malignancy. Finally, this patient underwent enucleation. Because of the rapid tumor growth, there was significant visual loss, and also there was an extensive optic nerve head involvement. So histopath I have of the enucleated specimen. You can see that there is a dome-shaped pigmented tumor which is arising from the choroid, but not from the optic nerve. There are no melanoma cells in this portion of the optic nerve. I want you to notice what slides B and C. Is there any difference between them? Anybody can answer. Do slides B and C look the same, or are they different slides? Okay, so both B and C slides are of the same slide actually. It's just that you're able to see C better because it is a bleached preparation. Bleached meaning it has been treated with potassium permanganate and oxalic acid. It is stripped of its melanin, and you're able to see the cells and the nucleolus much clearer. So this is something I learned. And new thing I learned. Optic nerve head melanocytoma transforming to a melanoma. So the differential, when it presents like this with a choroidal melanoma, it becomes very challenging. The malignant transformation occurs in around 1 to 2% of the cases with progressive increase in size and extensive involvement of the disc. Risk factors for malignant transformation include there's a rapid tumor growth, increased pigmentation, size is also increased more than 2 mm, and there's extension into the peripapillary retina, choroid, subretinal fluid, vision loss also, intraocular hemorrhage, and optic disc edema. Many reports have identified transformation within 5 years of the initial manifestation, although they can appear even after 17 years also. Treatment usually, if we are seeing that it's going into malignancy, then always do a biopsy. Plaque radiotherapy or proton beam therapy is done if there is a localized melanoma. Enucleation is done for extensive tumors. Always do a metastatic evaluation if there is extraocular extension noted. Okay, coming to case 8. This is a 58-year-old female who complains of black floaters of the right eye since 2 months. Visual acuity was 6.18 and she's phakic. So, yeah. This is a Claris image of the right eye which shows a pigmented subretinal lesion which is appearing slightly elevated. You can also see the RP changes and SRF changes also over it, and there's also fluid. Subretinal fluid. Ultrasound was done. Ultrasound shows a small retinochoroidal elevation There is also moderate surface and low internal reflectivity with choroidal excavation also seen temporal to the optic nerve head. MRI with contrast was done. I don't have the image. It shows a small elevated lesion in the superior temporal right optic disc. It has an intermediate T1 signal and a hypointense on T2. That was done, which shows the presence of a diffuse retinochoroidal elevation inferior to the fovea with subretinal deposits, and also there is subretinal fluid, and you can see these two hyperreflective elevated lesions just seen sub-RPE. They are nothing but shaggy photoreceptors, meaning the photoreceptors are very much swollen. And FFA ICGA was done. As you can see, it is a hypofluorescent lesion with slight hyperfluorescent in between it, and which progresses to become hyperfluorescent on the late stages. Whereas on ICGA, it is a hypofluorescent lesion, hypocynescent lesion, and a blocked fluorescence is seen. So a diagnosis of a small choroidal melanoma was made. The patient was treated with transpupillary thermotherapy, which was done in one sitting. Usually TTT utilizes this diode laser, which raises the temperature within the tumor, thus causing the heat-induced sclerosis of vascular channels and regression of the subretinal fluid. Patient was followed up after 3 months. This is the 6 months image, 6 months Claris photo. You can see where there is a scarring adjacent to the lesion, and also you can see the pigmentation very much clearly. Same thing on OCT. You can see that there is RP atrophy and the lesion has completely reduced with scarring. So we'll just discuss when we learn a little bit more about the tumor. 44-year-old male who presented with metamorphopsia of the left eye since 6 months. He also had flashes. Visual acuity was 3/60. There's an optos image where you can see an elevated dome-shaped lesion. It's brown colored, and you can also see surrounding subretinal fluid also arising superiorly. Inferiorly, you have an exudative retinal detachment. Ultrasound was done, which shows an irregular lobular mass within the vitreous cavity. There is a high surface and homogeneous internal reflectivity along with exudative retinal detachment, and there's an acoustically hollow zone which is seen. So the things to notice are, it is not like your regular tumor where you have a collar button like stud or like a mushroom appearance. It's very much irregularly and lobulated. So always when you see such thing, always think like there is some hemorrhage or necrosis which is ongoing within the tumor. So this slide was, I just kept it for the PGs to understand. What does high internal surface reflectivity mean? It is due to the numerous echogenic intersurfaces on the surface of the tumor. There's a moderate to high internal reflectivity because these tumors, which we all know by now, it's a melanoma. So they are densely tumor cells which are all packed. And since the echoes are not going through, there is a sound attenuation which is going through the tumor where you have a rapid decay of the spikes seen on A scan. So that's called steep angle kappa. And there's also acoustic hollowing for the same reason. Orbital shadowing. Extraocular or scleral extension should always be noted for. And the collar stud or the mushroom, what we call, is due to the break through the Brooks membrane. Also look for choroidal excavation. MRI report was done which showed a hyperintense signal on T. There was no apparent contrast enhancement because the tumor cells do not take up any contrast. Whereas there was low signal intensity on T2 along with the retinal detachment, as you can see. Histopathology was done. There were a lot of tumor cells infiltrating the lymphocytes. You could also see the epithelioid cells, which are the round cells, and the spindle cells, which are like palisading. There's also the presence of the pigment, and BAP1 was negative. BAP1 is the tumor suppressor gene, which was negative in this case. And the diagnosis of a large choroidal melanoma was made. This patient was finally enucleated. Enucleated specimen shows a mixed cell type with epithelioid cells and spindle cells, and it was a multifocal tumor which was infiltrating lymphocytes also. So choroidal melanomas are malignant tumors of melanocytes arising from the pre-existing nevi. Most common primary intraocular tumor in adults. Around 30 to 50% of the patients with medium to large choroidal melanoma have a poor mortality rate of around 10 years. Tumor spread may be seen along the vortex veins into the orbit without any direct extension. There's been described an indolent variety where there is increased scleral concavity or posterior scleral bowing, which is noted at the base of the tumor. It's seen in younger patients. Ultrasound is usually confirmatory and it's for monitoring. It has a 95% of a diagnostic accuracy. OCT to look for the retinal fluid or the retinal elevation, MRI to look for whether it's hyperintense or hypointense, and FFI you have this double circulation pattern. So what is double circulation? Where you can see the retinal circulation and the choroidal circulation within the tumor. This is only significant for choroidal melanoma. Image is by Dr. VK sir. Genetic alteration in melanoma. So the boxes in the red indicate that it has a high risk of metastasis, whereas the boxes in the green are a low risk. So gain of 8q, monosomy 3, loss of 1p, BAP1 mutation, and PTP4A3. These all carry a high risk of metastasis. Genetic markers like GNAQ, GNA11 mutations, they are of early driver mutation, suggesting that probably he's getting a malignancy. BAP1 loss and monosomy 3 have a high metastatic risk, whereas chromosome 8q have an aggressive tumor behavior. Other poor prognostic factors are like diffuse melanoma, ciliary body location, extrascleral extension, rapid growth, and older age. So how do you treat? So as we saw a small melanoma in the previous case, they were treated with transpupillary thermotherapy, where you have a tumor less than 4 mm in thickness and less than 12 mm of base. And plaque brachytherapy is for medium-sized tumors less than 20 mm in base and 10 mm in thickness. Proton beam is for mostly if it's optic nerve adjacent, and if it's more than 8 mm and 2 disc diameters within the optic disc. Enucleation is done for large tumors who also have a painful blind eye. Exentration is for extraocular extension. So metastasis, the most common site of metastasis in melanoma is 93% of the time it's liver, followed by lung and bones. Survival rate without treatment, these patients, they have around 6 to 12 months post-metastasis of survival, whereas with treatment, it's improved. So after the melanoma, you have enucleated, what do? You call the patient back for every 6 months along with a liver MRI and a PET CT. Just keep looking for METs. Liver function tests for early metastatic detection. Newer advances are like tebentafusp, which is an FDA-approved targeted therapy for metastatic cases, has been come up. It's not in India yet, but it's a bispecific fusion protein which is targeting GP100. It's a melanocytic antigen which is expressed both in choroidal and uveal melanomas. So human trials were conducted, and it has showed that 2 patients have achieved a partial response in among 84% of metastatic patients and 16 of uveal melanoma patients. Differentials are pigmented lesions, choroidal nevus. It also exhibits like numerous surface drusen's and all. Melanocytoma, chirpy lesions, which are congenital hypertrophy of the RPE. You have hemorrhage in the subretinal space, or metastatic cutaneous melanomas. Non-pigmented include circumscribed choroidal hemangiomas or any solitary choroidal granulomas or posterior scleritis. So this is our last case for today. Finally. A 58-year-old female who had a diminution of vision and flashes since 3 months in the right eye. Visual acuity was 3/60. So patient was actually pseudophakic. So what you're seeing is the central, which is clear because she underwent YAG capsulotomy, and the periphery, it is hazy due to the PCO haze. It's not clear here, but you do see a lesion superior temporal to the fovea, which has this slightly pigmented, and irregular borders are there. I'll show you the autofluorescence. You can see a hypoautofluorescence, and just inferior to it, you can see a hyperautofluorescence just emanating inferior to the lesion. OCTA scan was done, so we were suspecting like any CNVM or some other thing we were suspecting, but it surprisingly turned out like it was an elevated lesion with subretinal fluid, and there was no branching network which was seen on ORCC or any of the slabs. FFA ICGA was done. You can see this hypofluorescent lesion which is seen on ICGA, and it continues to stay throughout the phases. And ultrasound was done where it was a small retinochoroidal elevation with medium to high surface reflectivity. So a diagnosis of a choroidal nevus was made. Nevus are mostly benign intraocular tumors. They are congenital. They can be congenital or acquired. They arise from the neural crest cells. Predominantly they are seen in males. Predominantly seen in whites. Male to female preponderance is equal. They can be flat or elevated. Melanotic in 77% of the cases. Location extrafoveolar in around 94% of the cases, followed by post-equatorial and pre-equatorial. They are usually asymptomatic and are detected incidentally. Most of the complications of nevus include CNVM and subretinal fluid, and the cause is due to the leakage at the level of RPE. Systemically, it can be associated with neurofibromatosis or dysplastic nevus syndrome. The other variants of nevus are halo nevus, giant nevus, and melanocytomas. Treatment includes laser photocoagulation and intravitreal anti-VEGFs, transpupillary thermotherapy, and photodynamic therapy. So how do you differentiate this from a small melanoma? This was a nice mnemonic by Dr. Carol Shields. It's called TFSOM UHHT. So it's nothing but to find small ocular melanomas using helpful hints daily. If thickness is more than 2 mm with subretinal fluid and symptoms like flashes of floaters along with orange pigment which is seen, and they are less than 3 mm away from the optic disc with acoustic hollowness, and halo should be absent and drusen should be absent. These are the features suggestive of a melanoma. The one in the brackets is of a nevus. So to say that if it is a melanoma, minimum at least 3 major criteria should be fulfilled. So this was a case of a leaking choroidal nevus. So leaking nevus usually demonstrates, choroidal nevus demonstrates related overlying subretinal fluid within only 10% of the patients. Imaging with EDI OCT can be used to confirm the fluid, and FFA to determine the source also. If fluid is extrafoveal, you usually observe. Subfoveal, then treat with anti-VEGFs or PDT. It has shown that in 15% of the cases with choroidal leaking nevus, PDT has shown good response in around 87% of the eyes, and it achieves it in 1 session only. The differentials included are freckle. They are nothing but foci of choroidal hyperpigmentation with irregular borders, or chirpy-like lesions which have scalloped margins and seen in familial adenomatous polyposis. Thank you.